And we welcome our teacher, Professor Dinakara sir, again for his lecture. Next to us going to be interesting. Today we're going to discuss about cardiac chambers, isn't it? Cardiac chambers and
Yeah, function.
just a minute, sir. Yeah, you can go ahead, sir.
Yes,
We'll
sir.
go ahead and as Dinakar sir said, after towards the end of the class, for 15 minutes, sir will give us a small, a brief talk on his experience in Japan and how they are able to save babies less than 600, 700 grams. And he says, according to him, this is a very important part of this talk. And the fresh newborn, neonatal postgraduates will be very much benefited by this particular advice. So we are all waiting for that 15 minutes also. Without much delay, I think we will hand over the train to our professor, Dr. Dinakar.
Yes,
Sir,
sir.
Dinakar, sir, go ahead. Thank you.
Thank you, sir. Uh, Thank you, Kamal, sir. Dr. Prashant.
Yes, sir. Yes, sir.
Prashant,
Yes,
can
sir.
you
Yes,
mute
sir.
every?
Yeah, I'm doing, sir.
Yeah, Prashant, can you hear me now?
Yes, sir. Yes, sir. Go ahead, sir.
Yeah. So good afternoon, everybody. Just I want to thanks ICH Hospital and HCA Hospital. Kamal sir, with your blessings, I'll start the class.
Sure, sir.
And okay. So Dr. Kutesh sir, if you are there with your blessings, I am going to start the class. Kutesh sir, Prashant, please take care of all the logistics, dear.
Okay, sir.
Okay.
Okay, sir. Go ahead.
Okay. Today will be, because this is the fourth class, first we have done the basics views. As we were discussing with the Kamal, sir was telling, sir, your class is coming well, but we have to take the probe in our hand and we should do the functional echocardiography. Then we will understand more better. So there also, and he was telling, we are, I mean, in there, the echo machine in the NICU. So I request everybody, all the postgraduates, please take. I am seeing the first time the neonatology HOD and the director is taking much interest in echocardiography and ultrasound to teach the first year, second year, third students. So it is the first time because it is out of the curriculum. What it is not there, supposed to be there, it is not there at present. So, sir, thank you for your initiation, number one. And definitely ultrasound is your third eye, like Shiva. Because if you know the ultrasound, what is going on instead of the clinical heart rate, urine out. Yes, it's all clinically very important. But if you are having ultrasound, sir, heart rate is increased. Why it is increased? So there are 101 cause. What is the reason? Don't know. Sir, heart rate is increased, but BP is high. Okay, what is the cause? Don't know. Heart rate is raised, BP is low. What is the cause? Don't know. Means there are multiple cause. Specify, don't know, don't know. That is the reason. If you'll have the probe, ultrasound probe, echo probe in your hand, so if you will learn it, it will be very good, very excellent for you people. Okay. So now I'll start. Why to do it? Just now I was telling you people. How many we people know cardiac contractibility is good or bad? But BP is normal, mean arterial BP is normal, systolic BP is normal, diastolic BP is normal, but SpO2 low. SpO2 is also maintaining 89 to 90, but lactic acid is high. Okay, after lactic acid is high, then pH will start coming down. Then you means everybody we start pushing the fluid more to compensate dilutional acidosis. Okay, to make it dilutional acidosis. Then start soda bicarbonate. After some time, baby will have IVH. Otherwise, some abnormal things, then baby will succumb to death. Why it is happening? Because one of my friend from Bihar was calling every time. I am very happy to guide him. So unfortunately, he lost some 2-3 babies. He's a preterm baby. Sir, I know sir how to do echo, but I am losing. Then I told him when to see the sir kitab mein likhta hai na. Sir, it is there in the book. PDA will start after 24 or 36 hours or 48 hours. Pulmonary hemorrhage is more common. Then I asked, yes, it is written. But for which babies? Which gestational age? So no answer. Then I told him gestational age is important. As the preterm is very small, then the PDA is very small for that, even that. But if the baby is developing in the PDA Doppler steady growing pattern, then that is the time. Because 90% nowadays, everybody 99% probably or 98% probably, we are giving surfactant if the babies are very small, needing the surfactant therapy. So immediately within 6 hours, 4 hours, 8 hours, the lungs will start improving. Once the lung compliance is improved, so PVR will start decreasing. If PVR decreases, PDA will left to right shunt will flow. So that is the time if the growing pattern is there and the growing pattern is becoming more, that is the time to start the closing therapy, either brufen or indomethacin or paracetamol. Number 1. So he told me, doctor, I started like this, I started doing this, I started saving the babies. So that is the reason I request all my dear friends, not only simple PDA, when to look for the growing pattern. Is it 6 hours, 8 hours, 12 hours? Yes, if it is very small, do early. Start early treatment. That means, sir, do you think for all the babies should I start? Because within 24 hours automatically it closes. So if it is a growing pattern, my word repeat, growing pattern. Okay, growing, then becoming pulsatile pattern, that is a time to start and close it. Sir, I have started. Before that, is there anything before becoming a growing pattern and other things? But pulmonary hemorrhage is started early. Is there anything to detect? I am asking all of you people. You people are all very learned than me and more intelligent than me. And you people are my teachers. I request you, I am going to put one question to your heart. Before the PDA is there, before the PDA is having left to right shunt and becoming more pulmonary edema and baby is dying. Is there anything can cause pulmonary edema and pulmonary hemorrhage with IVH? Is there anything else or anything else we can detect? Oh, this baby can develop IVH, dear. This baby can develop pulmonary hemorrhage. So this is a baby will survive. I repeat, if I'll give this treatment, that baby won't develop the IVH or the baby won't develop the pulmonary hemorrhage. Anything like that, sir. Chef made the like a pocket. If I'll go in the aeroplane, they will give upma, palau, something, put the water instant. Like that, anything is there? I am going to tell you today after my 20 minutes talk, I'm going to tell you what I learned in Japan for 31 days. Really, it is interesting. I am following too. Okay, number 1, systolic function. What do you mean by that? Systolic. What do you mean by systolic? Myocardium is contracting and pushing the blood outside. Stroke volume. Against the systemic vascular resistance. Yes. How much blood is there in the my LV, example LV or RV, how fast it will pump. That is all the systolic. So please, dear friends, go ahead and read it and see my cursor. End diastolic ventricular volume. within the physiological range, increasing myocardial fiber stretching increases myocardial contract. That means we should need, means LV needs or RV needs preload. If there is no preload or less preload, stroke volume will come down. If stroke volume comes down, what? Okay, dear friends, that's what I have to go it. Something has happened here. Sharing, just check it. Okay, so I am going to tell you about this now. All my talk is depending on this one slide today. I know this is like a. This is
coming, ma'am. 1 second.
this. ಇಲ್ಲಿಂದ ತಿರ್ಗಾ ಶೇರ್ ಮಾಡು. ತಿರ್ಗಾ ಶೇರ್ ಮಾಡು, ಬೇಗ ಮಾಡು. Sharing, sir. It's going. Okay, bad network. It's not coming. Okay, nothing. Something is coming here. Prashant, can you hear me?
Yes, sir. Go ahead, sir. Slides and both are seen, heard properly. Go ahead, sir.
Okay. See, this is my slide. Please, if anybody is seeing in your mobile, please take a snapshot. Okay, please, everything, whatever my talk is there, I'm going to tell you all these things. Whatever last one ESWS, end systolic wall stress, it is the highlight of my talk today. End systolic wall stress, it is my highlight of talk today. Left ventricular contraction and right ventricular contraction is depending on how you are going to observe with the heart. The heart size is very big or not. Left ventricular is big, right ventricular is big, or left atrium become big, left ventricle become big, or pulmonary artery is becoming big, or pulmonary right artery is appearing single, because to rule out the congenital heart problem. And whether contraction eyeball on eye visualization, whether contraction is good or not, or tachycardia is there, a bradycardia is there, that you can visualize in the apical or parasternal or any view. At least you can see heart is beating or not. Okay, I am just telling you, sometimes monitor will be showing some ECG leads with the ventilator if you'll connect, but if you'll put the probe, heart rate won't be there. Okay, just I am telling you, that is called eyeball examination. So fractional shortening. In neonate, we do use maximum fractional shortening. Okay, ejection fraction we don't use because it is cubed here. Everything is cubed. Please, dear friends, see my cursor here. It is cubed. So this one, if one small mistake we are doing, it is all error is cubed. So we are not doing much. So how to remember EF, ejection fraction? Sorry to use something slang word, but to make you remember, I am using little slang. Ejaculation won't come in a neonates. So that is the reason ejection fraction we don't do in a neonate much, but we use maximum in a adults. Fractional shortening we do in a neonate. This is fractional shortening. So nothing is cubed here. This is left ventricular end diastolic diameter. Left ventricular end diameter. That I'll show you. That already I showed you. Then that same thing into 100. What is the 23 to 40? 23 to 40 is normal. Okay, then what is velocity circumferential fiber shortening? That is also very, very, very important. Why many people we don't do this study? Many people are not using, they're doing this, they're coming to the conclusion. Dear friends, now this and this, whatever I am showing, this one and this one, try to do it yourself. It will be very useful for this. Because what I have seen in Japan, they are always I have seen there that first year fellows, they are doing this. First year fellows, they are doing this. And they are deciding immediately after birth. Then they are doing for 8 days continuously. If the baby becomes sick, then they will do this first and they will decide what to do, what not to do. Okay, then MPI, I already show you myocardial performance index yesterday. Left ventricular output, right ventricular output, end systolic, that's what. This is all the systolic functions of the right and left ventricle. This is all the formula of only systolic things. You have to, because if you keep on doing, it will become in your, like just in your mouth. You need not mug it. You need not mug it. First thing, oh, so many things are there. I cannot do it. So diastolic function, once again, E wave, A wave that I showed you yesterday. Pulmonary vein, I showed you how to flow. Superior vena cava flow, why it is? It's all still in the tube line or pipeline, still the thing, whether I have to do for all the babies or not. If you are learned little more than the basics, then superior vena cava flow is also must. If it is less than 30 or minimum should be more than 35 to 45 ml. If it is less than that, that means this baby will develop 100% neurodevelopmental complication, or this baby will develop IVH. You can at least tell this baby whether this baby is prone or not. When you are going to do that, if this one is very high, if this one is very low, then if it is necessary, then you are going to do the pulmonary vein. Sorry, superior vena cava flow. So you are going to do the superior vena cava flow. So yeah, everything is telling, then you should immediately act and change your inotropes. That is the reason. If you don't know the echo, learn it. Nothing is, oh, I cannot, my age is over, I became professor. Dear friends, I also learnt when I was around 30 years old. Now I am almost 49, 48 years old person. Okay, why I am telling? Time is not a constraint. You should learn, because when you learn, your teaching method will change. Okay, at least in what all the ways you are going to do the systolic function, either right or left, parasternal long axis. Just everybody should remember parasternal long axis when you are doing standard parasternal long axis. If you will tilt your probe towards the right hip, you are going to see tricuspid valve. If you are turning your probe superiorly towards the left shoulder, just it is called tilting, I am telling, or angling, I am telling. You are going to see pulmonary valve. So if I want right ventricular output, so you're going to see the parasternal long axis superior view, apical chamber view, LVO view, and all the contractions, whether it is there or not. Parasternal short axis view, you can do it even for the M mode for the fractional shortening. Everything I'll show you, ejection fraction, fractional shortening, and ESWS, everything you can, only these three. You have to know this. First, visual impression is the best, whether heart is beating or not first. If you come to know it's beating, whether it is tachycardia or normal, slowly you will come to know. Just check your monitor. When you see my eyes, check the monitor, check your cardio, what is it, echo machine. Okay, heart rate is 140, it will. So memorize that picture, then you will come to know tachycardia is there or not. Okay, if it is bradycardia, check the heart rate in the monitor, check the how it is. Okay, this is bradycardia. Visual memory. Then contraction, whether it is kissing, means it is pressing like this, kissing ventricles, whether it is coming like this, just poor contraction, that also you will know. Everything, if you want to take measurement, M mode is very good. M mode is very good. That is called a motion mode. What you are seeing the picture is 2D mode. See this one, just once again assessment of the right ventricle. See, I showed you this. See, it is a normal. What happens here, dear friends? This is right ventricle. This is the left ventricle. So then what happens? This IVS is becoming flat here. So left ventricle is become D-shaped. Left ventricle become D-shaped. So what happens here? This is pushed down. See here, IV, intraventricular septum is coming crescent shape. That time this is also becoming crescent shape, like a Chandra, like a moon. Is the one. That time you can tell mild, moderate, RV. Is it difficult? I told you eye visualization, heart rate, hypercontractile or poor contractile, and the shape of the ventricle. Come to the fractional shortening. How to do the fractional shortening? Here we are keeping the probe. See, this is a long axis. This is a parasternal long axis. Right ventricle, left ventricle, aorta. So this is a left atrium. Putting probe slightly at the mitral valve leaflet tip. It should be perpendicular to the IV. What is that? Intraventricular septum. It should be very perpendicular. My words are very clear, dear friends. It should be perpendicular. That is the way you are supposed to get the parasternal. See here what happens parasternal. It is going little higher above. So this is a very bad. Let me tell you, this is a very bad. Okay, it should be like this. Apex should come to the straight. It should be very perpendicular. This is the proper way. And what is the posterior wall is? This is the posterior wall. Posterior wall. What is this? Is from here to here mitral valve chamber. That is the place where you are going to measure. And left atrium where you are going to measure. It is exactly where the maximum chamber is there. And that is also perpendicular to the aortic wall. Perpendicular, perpendicular, I repeat. And when you put the M mode, you are going to see the inner to inner wall. Not outside wall also I will take. Who told you to take outside wall? Chamber means inside. You cannot take wall also. Very clear. The preterm babies 23. Remember like this, 25 to 40 is normal. If it is anything less than 25 is dangerous. So more you think of something else. What could be? If more means volume is less, heart is pumping more. So volume is less, so contractibility is very high. Means LVID will become like this, LVST will come down. So the shortening 10 centimeter, 4 centimeter means 6 cent. This is 10 centimeter. This is 4 centimeter. The difference is 6. Where you will get hypercontractile heart with almost kissing papillary muscles. It is very good. Fluid less means hypovolemia. Very good. See this beautiful. All are depending on this. Okay, that is very, very important. Please remember this. And please remember the normal values. Next, I'll go to the fractional shortening is finished. I told you what is the method of taking. So I am showing you what is the wrong thing here did. Sir, I cannot take in a parasternal long axis because you told me heart that this thing should come. It is a parallel, it should come. I am not getting, I am getting is no problem. Take a parasternal, what is it? Parasternal short axis. And this is a papillary muscle. You put it in between 101% you will get because it is an easy way to put it. See, dear friends, this is the way. Because nobody will teach you all these minor details. If you are finding what is the correct position of left parasternal, so please catch it. Same thing it is true. Same thing it is. Okay, so just go through this. So 25, 30, if you will remember, FS and EF, because machine itself will give the calculation because all the machines will be having. See, this is velocity of circumferential pipe 30. What I am telling ejection fraction. Prashant, Dr. Prashant. Prashant. Can you hear me now? Can you hear me now? ಸ್ವಲ್ಪ ವಾಲ್ಯೂಮ್ ಮಾಡ್ಕೊ. Prashant, can you hear me?
Dinakar sir, we can hear you.
Yes, yes. So, velocity circumferential fiber is the same thing like Fs, but there it is depending on the volume, preload, heart rate, everything it is dependent. Okay, and any compression or something like that. So, but this one is also depending on the heart rate and slightly preload, but not as that Fs. So that is the reason what happens, that is velocity circumferential fiber means, just see my hand. This is full now hard. So it is compressing. How much it is compressed? How much it is compressed? Once again full. Whether all the fibers are compressing at a time or not. Augmented hold on. Looks something wrong. Bye. Okay. So this here what I am going to do is, I am going to take, instead of 100, I am going to take left ventricular ejection type. I am going to take left ventricular ejection type. Same LV, diastole, systole. Okay, this is the wrong thing. Okay, systolic diameter, correct. This is the thing, it is correct. Left ventricular ejection. I will show you what is that corrected. Suppose if heart rate is very high, if heart rate is very low, you can correct with the RR. That also I'll show you. Please remember, this is our motto: 0.8 to 1.1, at least 0.8 to 78 or 8, whatever it is, 0.8 to at least it should be 2. If it is less than 0.8 means, that means it is not able to that compress. That heart is not able to compress, either due to what is a dilated myocardium, or afterload is increased, everything. Okay, dear friends, this is the one you should know. Now come to the MPI. All the, whether left ventricular or right ventricular is performing, yes or no. This is the way you should remember. What is this is, I kept it the probe pulse wave Doppler near the mitral valve. This is E wave, this is A wave. EA, early filling atrial contraction. So this is a second one. So from here to here, this is the ejection time. First, what I will do is, see this, here to here I will take. Complete from here, see this, from here to here is IVCT, IVRT. Okay, divided by this much portion. That also easy way is this. Easy way is from here to here, E wave to A wave, you take measurement, then you take this one, this is this thing, then do the calculation. I am going to show you very easy method, MPI, and what is the normal value of MPI also. Because if you will know that MPI, what is the normal value, it will be very easy, dear friends. See, this is the value. If the values are more, that means myocardium is stressing out. It should be less than 0.4. Okay, remember that. And cardiac output I showed you how to take. Then diastolic function, E wave and A wave I told you. Please, dear friends, diastolic function I told you. Usually in us or in a term baby, what happens is, remember, in term baby, all the vessels will develop their own Z score, means their own resistance. early filling will be more. Early blood will flow to the ventricles from the LA. Then some minimal amount blood will come from the atrial contraction. So E wave is more than the A wave. But in the preterm babies, since the SVR means systemic vascular resistance is high and compliance
I think he'll join back. There is some technical this thing. He'll join back. He'll join back in a minute. Is it audible now?
share notes. Hello. Hello.
Slide share ಮಾಡಿ. ಸರ್ ಕೇಳಿಸ್ತದೆ ಇವಾಗ. ನಿಮ್ದು ಇಂಟರ್ನೆಟ್ ಕಟ್ ಆಫ್ ಆಯ್ತು ಸರ್. You can start sharing the slides. Video on off ಮಾಡ್ಕೊಳ್ಳಿ ಸರ್.
ಆನ್ ಇದೆ.
ಈಗ ಕೇಳಿಸ್ತದೆ ಸರ್. ನಿಮ್ ವಿಡಿಯೋನ ಆಫ್ ಮಾಡ್ಕೊಳ್ಳಿ ಸರ್. Streaming will be better. Please switch off the video, your video, and keep only audio and presentation.
Can you see the presentation now?
No, sir, not yet, sir. You have to stop and restart the presentation, sir.
Now, can you see?
Yes, it's coming now. It's coming now.
Diastolic function. I was telling, please, dear friends, sorry for the interruption. So there is like this. So what happens since it's a preterm baby? What happens is compliance of the left ventricle is very narrow and small and reduced. At the same time, SVR systemic vascular resistance is so atria has to pump more. That is the reason 1:1 will be there.
Slide is not seen, sir. Only it just Dr.
Prashant, can you hear me?
I can hear you, sir. Slide is not seen, sir. Slide is not seen.
It is not seen.
Okay.
Dr. Arsh. Just
yes,
stop sharing and
we
then
are here.
Start sharing again. It will come.
Okay, sir.
Able to hear. We can see that now. We are able to.
Yeah, we can see the slides now.
Okay, sir. Okay. So, so area slide. slightly high, slowly, but see here what happens is if the ratio is less than 0.6:1, as the atrial contraction increases, that means a right ventricle or left ventricular is failuring. Number one. See here what happens, dear friends. If baby, slowly baby becomes all right. More veins. This is the right upper. This is the systolic. This is the diastolic of the ventricle, whatever atria and ventricle, and this is the atrial contraction. Suppose atrial action is coming down. That means that is the early indicator of diastolic dysfunction. Number one, remember. So superior vena to see the superior vena. Dear friends, I showed you suprasternal. This is the first view. This is the first view. Once again, please see my cursor. This is SVC. You can see very clearly here. You can measure it exactly here. That I'll show you today. I'll show you today.
The slide is not moving. It is still in the diastolic function slide. Okay, now it's moving. Now it's moving. Go ahead, sir.
It's okay.
Yeah, it has moved to the next slide. The SVC flow is identified by angling. Yeah. Pulmonary.
The maximum and minimum internal diameters.
Yes, sir. Yes, sir. Yes, sir. Superior vena cava flow. We can see that slide now.
Yeah. Prashant, keep on talking some things if you are not able to see.
Sure, sir. Sure, sir. Go ahead, sir.
Though, how to see this? This is the way you're going to see. I cannot hear. Okay. So diameter can be measured from the frozen image. Frozen means freeze the image and you can measure directly like this. Or you put the M mode. You can see very easily in the M mode. What I will show you how to measure. So this is the one. So parasternal. This is the subcostal long axis view. See here, sorry, short axis view. This is the one where you can see SVC flow. See this? Right atrium. This is superior vena cava. This is inferior vena cava. This is right atrium. This is superior vena cava. You can see blood is flowing. See, this is the way, subcostal view. For the flow, that also I'll show you. So very, very important. Everybody knows who is Klocknow and Evans because we have seen him in the many 2-3 conferences. We have seen him. So they have studied superior vena cava flow. If it is less than 45 ml, take a caution. Take a caution. Take a caution. If it is coming down to 40, take care of whether PDA is there to close or not. See, there are many ways to close the PDA. There are many ways to close the PDA. Okay, or there is some compromisation is there, or MAP is low, or BP is coming down. Cerebral BP, CBF, cerebral blood flow is coming down because 37% of the LV output will go to the upper body. So upper body means maximum brain. 30% of the blood should come back from the SVC, means superior vena cava. If it is 37% of the blood, whatever the LV flow is not coming down from the SVC, that is example 30 to 45 ml. That means there is diastolic steal or CBF is less. CB means cerebral blood flow is less, or MBP might be less. There are so many causes. I'm not pointing out to only MBP, CBP or whatever it is. So according to the Klocknow and Evans, 5 hours it should be like this. Minimum, the range. If it is less than 40 to 30 ml, if you are taking a risk, those babies will develop 101% will have a, what is this? They will have neuronal developmental problem. Please, dear friends, understand. Okay, come to this. Now, I told you above vein, that is called superior vena cava vein. Come to the inferior vena cava vein. Many people will get confusion. What is this? Dear friends, if the baby is breathing normally, what happens during the inspiration, all the blood will go to the negative, because of the negative pressure will go to the heart during the inspiration. If it is a normal breathing. If it is a ventilator, it is vice versa. Okay, you know that is the reason. You will find if the patient is on ventilator, because of inspiration, what happens? It will become big because everything is compressed. Inspiratory volume is coming and lung is expanding. That time, whatever the blood is there, RA, RV or RA, it is pushing back to the SVC. So IVC is becoming big. This is inspiration in the ventilator, but exactly reverse in a normal breathing. That is the reason they found out two. Remember, that is the reason normal breathing and ventilator breathing. They found out two calculations. See, because sometimes if we see, it is like a spoon feeding, dear friends. Please take it right now. Distensibility index. Sorry. Okay. This is called a ventilator is distending the lungs like a PEP. That time what happens if the baby is on ventilator, you are going to use distance. What is the formula? Maximum diameter, minimum. Here also maximum diameter, minimum diameter. Only here what happens is minimum diameter is going to be there. Here mean diameter is there. That is the difference. Max, same max, minimum same, max same, minimum same. This is spontaneous breathing. That is called collapsibility. Here it is called distensibility index. Here it is 18%. Here it is 12%. If it is more than that, you are supposed to give fluid. How you are going to see that? M mode. That also I'll show you. This is the way M mode. So maximum, minimum, then calculation, you are going to see that. Okay, that also. See, today my talk about this is, please dear friends, everybody can listen. What I learned previously in my 14 years of life, keep apart. What I learned since 5 years is keep apart. Everything in the echocardiography, hemodynamics, everything is changed. My life is changed only because of that 31 days. Please, dear friends, you're going to take now whatever I'm talking about. Please, if you are having paper and pen, write it down. I'll go very slowly, very slowly. Okay, I'm going very slowly. You are taking either parasternal short axis or parasternal long axis. You are putting the M mode. And you are taking left ventricular internal diameter. Left ventricular internal diameter in systole, that is the minimum, and maximum, that is diastole. And I have taken this one where my cursor is there is a pericardium. From here to here is posterior wall. Left ventricular internal diameter during the systole. Where you have taken parasternal long axis or parasternal short axis. So what extra I measured here is posterior wall I have measured. That's all, dear friends. That's all I measured. Then I measured one more thing here is RR interval. Here ECG, because if you are doing echo, in the echo machine will have a ECG leads. You can connect the ECG leads and you can do the echo and you can compare that echo whether it is systole, any abnormality. That I am going to take whenever I come to Chennai because it is little deeper things. This is RR interval. So how to take RR interval? Otherwise, you just take a left ventricular outflow. That is called a cardiac output. AO means aortic output. Ejection is there. Ejection. Now this is the ejection. Sorry, I'll show you here. Suppose if you are not having anything, see from here to this area, this is aortic area. You are taken from here to here, distance is RR interval. Means one portion to the other portion. You are taken. Even if you want to take from here to here in mitral valve, here to here is an RR interval. From here to here is an RR interval. So you have taken. So remember, external long axis, parasternal short axis. You have taken left ventricular full diameter, left ventricular full systolic diameter, posterior wall thickness with RR. Sir, can I not take RR interval here? Yes. If you are seeing my cursor, please see here very carefully. See, this is the one. This is the one. Please, this is the one. What is this? Aorta. Aorta, what is there? This one and this one. Can you people see here? Yeah, everything can measured in a one angle only. This is the aortic hinges. Hinges means I told you door where that steel will hold that frame. So from here you take a measurement till here where it is closing. See, it is up. This is the lowest down. From here to here if you will take, this is called left ventricular ejection time. Ejection time. Why you need this left ventricular ejection time? For velocity circumferential fiber shortening, because LVID minus LVIDS divided by LVID into LVET. That is okay. See what you mean by end systolic wall stress. I want from tomorrow, please take a snapshot. Everybody in your hospital, try to do this, dear brother. Please, dear friends. This you will go and tell, sir, this baby needs ionodilator. This baby needs ionoconstrictor. Okay. Because premature baby will have a different, means abnormal receptors. What you mean by abnormal? Not developed properly. Or if you will give 1 microgram per kg, erratically it might consider it is 10 microgram you are giving. Or if you'll give 10 microgram, it might, because of receptor abnormality, it will take 1 like. Or since beta 1, beta 2 receptors are there, either it will cause chronotrophy as well as ionotrophy. And alpha 1 receptors are also there. So increased vascular resistance can occur even in dobutamine in a preterm baby. That is the reason nowadays, if you will go very deep, see what I learned 4 or 5 years back, dobutamine will cause vasodilator little effect. Yes, it will cause little vasodilatory effect. But do you think it is for same for all the babies? It is not. For smaller baby, it might cause increased SVR. SVR means systemic vascular resistance might increase with the chronotrophy. Heart rate also can increase. So for dopamine, just screw him, idiot fellow. Idiot, I don't know who is that idiot. Okay. So where I was, sorry dear friends. Okay. So what happens is, so they have what they were telling us, and they have given me one article. They told me, doctor, why can't you read this? I read this, I understood, but I'm not able to believe it. I'm not able to believe it. So there, one doctor has showed me, see, dobutamine I am giving. See, this is the things will happen. Then what he has told is 4 to 5 microgram, just minimal, he started dobutamine. Then he showed the end systolic, during the systole, that also end systolic wall, how much it is having stress, means that wall thickness, whether it is increased or decreased. Increased or decreased? What is happened? So he asked us to see. Whatever I am showing you, this is article what he gave us. And he showed me practically. That is the time I learned. So then he told, see doctor, this is the baby, I am giving nitroglycerin. That is a dilator. So that vasodilator, then he showed how many days he wants to give. Then I told you nitroglycerin will cause coronary vasodilatation, PDA will open. Then he showed 0.3 microgram per kg per minute. Once again I repeat, nitroglycerin 0.3 microgram per kg per minute to 1.5 microgram per kg minute. Either this is not increase the coronary vasodilatation, nor it is increase the or affected the PDA closure. I repeat, not affected the PDA closure too. At the same time, milrinone has caused some abnormality in the PDA closure. And dobutamine say to be used for the PDA when it is opened much, they told it is having abnormal reaction in the SVR. That is the reason babies will have abnormal neurodevelopment, cognitive, even if the baby survives, it is from the God or powerful, or if it survives, it will have some cognitive functions, or if it survives, it will have some mortality like IVH, or because of SVR, lactic acid will rise. That lactic acid will cause abnormal problem in the other organs. I was shocked to see, dear friends. Then this is the formula that Japan people are started using, and they are using right now. I told you first year people are doing it in the NICU. That is the reason 300 grammer babies are surviving. And in America, one baby called Linda, it is 346 grammer babies survived. And the treating doctor was from Japanese doctor who has gone there and tried this, and she saved the baby. Baby of Linda. You understood what I am talking to you people. Okay, now see here, please see this 23, 24. Velocity circumferential fiber shortening should be minimum at least 0, just it should be more than 0.8. It should not be less than any time 0.8. Number one, velocity circumferential fiber shortening, because FS fractional shortening and EF is depend on preload and once again depend on afterload. But this one can detect even preload, afterload. If any problem, even heart rate will rise. This can detect. There is problem is early problem is going on. Please treat me. So early only you can catch. So velocity circumferential fiber, what happens is, dear friends, please see this. Whenever what is this is called ESWS, end systolic wall stress, from 30 to 45. It should be minimum 30 to 45 they are taking into range. That time velocity circumferential fiber is maximum more than 0.8 and above. But they are trying to keep for more than 1 VCF. Velocity circumferential fiber shortening corrected. They are trying to keep it. There is one more thing called a mean, that you need not worry about the mean and all those things. That I will show you today. See, this is the one I want to show you. See, 0.8 at what? ESWS is 40. See, ESWS is 40. It is more than 1 or 0.8 or 9. See, all the things. So here group 1 and group 2. Group 2 are having whichever the group 2 babies they had. Babies were very safe without IVH, without cognitive functions, neurodevelopmental problem, without any pulmonary hemorrhage. All those babies are had ESWS is less than 40. Whichever the babies who ESWS, end systolic wall stress is more, MCF is started coming down, had pulmonary hemorrhage. Okay, this is the one I don't want to talk more on this. Mechanism. Please, dear friends, whatever I talk now, just 5 minutes, listen to me carefully. Don't even write down. Don't even see that side or this side. This is the one I learned from them. This slide, this PPT slide. Mechanism of afterload miss. Can anybody here, just it is a request from my side, not to test anybody, dear friends. Can tell me what you mean by afterload mismatch? Please switch on your mic, because what I am only talking, nobody is talking here. It should not be like that. Please, dear friends, somebody, whatever, even wrong, right, no problem. Afterload mismatch means what? Can anybody tell me, dear friends? I will hold on. Switch on your speaker and tell me. Prashant? Hello?
Sir.
Please, anybody, what do you mean by afterload mismatch? Any person, because I want it to be an interaction, because I am giving a small teaching from my side. I am really interested teacher to teach the people. I am very happy, Kamal sir, you have given me the chance to teach. Really, I am lifelong, I am thankful to you. Because what is my passion, I am trying to spread to the people.
Sure.
Anybody can tell me what you mean by afterload mismatch?
Sure.
Okay, can I start, dear friends? Can I tell you what is afterload mismatch?
Sure, sir.
Okay, please, whatever I am talking, don't get confusion. Follow with my words. Follow with my words. Your frequency should be there with me. See, blood, if the preterm baby is delivered or any baby is delivered, first I'll take about the preterm baby. Listen. If preterm baby is delivered, immediately what happens? We are going to cut the umbilical cord. What happens? Usually what happens, systemic vascular resistance is increases. That everybody knows here. That myocardium, according to that preterm gestational age, the contents is decided, that everybody knows. There is a flow chart according, not flow chart according to the gestational age, myocardial composition. That everybody knows. I don't want to talk. Now, blood has to flow. Right ventricle has to pump the blood to the pulmonary. Pulmonary has to send the blood to the LA. LA has to pump the blood to the LV and systemic. So it will keep on happening. So here, since there is a minute thing is happened, what is happened? Minute thing, SVR is slightly increased, but myocardium is, and myocardium is contents are very almost gelatinous, watery. Myofibrils and T fibrils, T cells, terminal, whatever it is, it's all very low. Contraction capacity is less. Still blood is coming, myocardium is pushing the blood. Blood is coming from LA, myocardium, LV is pushing. So what happens is, slowly lung is started improves. More blood is started flowing from the lungs to the LA. Please catch my words here. Catch my words. But SVR is same, or probably more for that LV. What it was compressing previously happily to the low resistance placenta. More blood is started flowing. More blood is started coming to the LV. Yes or no, dear friends? That time what happens? Some amount LV, array, you have come to me, I will accommodate like Indians. Like Indians. You also come, you also come. At last, we only won't be having house. Like that, LV started accommodating that blood. LV is stretched. See my hand, LV is stretched. Okay. After some time, some more blood is started coming. LV is little more stretched. So some more time, some more blood is started coming. LV is more stretched. Here, there is called Frank-Sterling law. Means more it stretches, more contraction it will develop. More it stretches, more force of contraction it develops. Once again, more it stretches, more contraction will develop. But it is accommodating more blood, pushing the blood against the more SVR. But for everything there is a limit. For everything there is a limit. So once again, LA, okay, I am sending the blood to the LA. Lung will think I am sending the blood to the LA. LA is pushing the blood to the LV. LV is pushing to the AO. So there is no problem. Like that, more blood is started flowing. That is the time LV is started having more load, cannot pump as rapidly as previously. More than around 2-3-5 minutes back it was used to pump. 2-3 minutes back or 5 minutes back or 10 minutes back it used to pump. Because more blood is started flowing, it is stretched. Left ventricle myocardium is stretched more beyond the limit, like a balloon, where like a PEP can be maximum. After that there is no use. Like that it cannot stretch more. That is the time. That is the time where it cannot have that same contraction, but more blood is there. That is called afterload mismatch. The definition of word in cardiology is afterload mismatch, because of increased afterload. That is the reason, dear friends, when the systemic hypertension is there, left ventricle start failuring because of afterload mismatch. So mismatch is happened. What is there for that? Slowly, dear friends. So I showed you. Okay, slowly what happens? Once the afterload is mismatch is happened. So LV is started dilating. If LV is started dilating, it will put the pressure on the IVS, intraventricular septum. If it is pushing the pressure on the IVS, IVS will bulge towards the RV. RV, it is bulges. What happens? RA blood cannot, that whatever the pressure, it will slowly revert back to the RA. That pressure, it is reverting back venously to superior vena cava and to the brain. As the baby, I am telling, I am repeating, from 23 weeker, germinal matrix is completely surrounded. That is, surrounds the complete ventricles. So 26th weeker, it is a rich thing. At 34 weeker, it comes and sits in the cardothalamic groove. So if the baby is 23, 24, 25 weeker, minimal flow, minimal pressure. See this? See my hand? This side little pressure and baby is coughs. That cough of thoracic pressure is enough to cause a venous hemorrhage in the germinal matrix. Leave about ventilator, leave about HFOV, leave about PEP, leave about tracheal suction, and leave about pulmonary constriction because of the trachea. Will push the blood more and cause the once again pulmonary vein, from pulmonary vein to the RA, RV to the RA. All those things in turn causes venous hemorrhage in IVH. That is the reason. Please, dear friends, venous hemorrhage occurs in 23, 24, 25 weeker in germinal matrix because supporting structure are very less, dear friends. Now, okay, you understood IVH. Now I will go. Okay. How to manage? I will tell you later, dear friends. Okay. That also I will tell you. Come to now. Sorry. Okay. Come. Now what happens? So I told you IVH. At the same time, there is one more path is there. No. Where is that path? From LV, it is preload is increased. It is slightly dilated. So it cannot accommodate more blood. The blood will go to the LA. That LA will push back the blood to the pulmonary veins. So that is the time I told you in PPHN, pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure means from the capillary blood is started going back. More blood is collected because small tracheal section, lung is compressed, somewhere some acute somewhere that is like perpendicular or acute angle, blood is there, it can open up. So mild pulmonary hemorrhage can occur. That pulmonary hemorrhage, once the blood comes out, iron comes out. Then that one will cause inflammatory cascade. That is the time slowly baby will have minimal pulmonary hemorrhage and full blown pulmonary hemorrhage. If not, that portion will develop chronic lung disease portion or some problem, or underdeveloped lung later will have that minimal amount of lung, tomorrow that might this portion of lung. So now you understood what is the problem of IVH, how it will occur, how the pulmonary hemorrhage will occur. So all these things can occur over 6 to 18 hours, dear friends. Leave about, I am not talking about PDA, dear friends. I'm talking about all these things because of only simple SVR, increased load. Okay, sir, can't you detect this early, sir? Can't you treat properly, sir? Please, dear friends, learn the echo. One word, learn the echo. You can detect properly, treatment you can put, you can save the babies. That's what I'm going to say. So what they did is, what I came to know from them is, sir, you told me about the lung, no? We are sedating the baby with either fentanyl or morphine. It's very good. Morphine will cause pulmonary, sir. Theory, sir, morphine is better, or even fentanyl is also better. Okay, continuous infusion for 4 to 5 days, sir. It's more better. That is the time where after the birth, it is like a DDH. DDH means, I told you previously, I am always teaching my students called a link reading. Once I am teaching this, at the same time, there is other hook, you should hold it. In DDH, immediately after the birth, if you are not putting the caster, something within 6 hours to 4 hours or half an hour, they tell that whatever the birth process, that cartilage will become stiff. So immediately after the birth, if you diagnose as soon as possible, put the splint. Now pamper, double pamper, all the things, harness, gearness, everything is, now it is there, but is it useful? That is a different subject. Like that, here also, immediately catch it. Then what you are going to treat? Morphine or fentanyl for the sedation. And minimal ventilatory effect. So minimal HFOV. Minimal. And they are not going to try unnecessarily, remove 2 days, bubble CPAP put. Okay, it's not ventilated, not tolerated, put it. That is called intermittent hypoxia or desaturation. They never allow the baby to become, because that time BP fluctuation, CBF, cerebral blood flow will vary, that will cause PVL, periventricular leukomalacia or IVH. They never allowed to happen. They are keeping the baby 800 to 900 or 1 kilo if it is necessary, or 800, 900 grams. They are putting the baby on HF. Telling you people do it. I'm telling what they're doing. My words are clear. HFOV they are putting with a minimal amplitude, because MAP is stagnant. Minimal amplitude. So such that venous pressure variation they are decreasing. So constant lung opening with minimal amplitude, with minimal oxygen, everything will save the baby with the sedation. And come to that one. Then how they will prevent this thing. Suppose So they have studied totally 44 babies, that one study. Later they have studied now more than 1000 babies. So they started dobutamine 4 microgram to 6 microgram. They have seen it is increased SVR, but MCF is increased. MCF means, what is that? VCF, what is that? Velocity circumferential fiber flow is increased very much. But at the same time, oh, increased cardiac output. Don't be happy, dear friends, because chronotrophy effect is there, mild inotrophy effect is there. But what happens? Mild SVR is increased. You go to the deeper nowadays articles, dobutamine is not the first choice, even in the mild dose of PPHN. Mild dose of epinephrine is the first choice for the PPHN. You know why? It's a different issue. Here, what they did is they started dobutamine. They started VCF is increased. That means cardiac output is increased. Very happy. At the same time, SVR2 is increased. So that how they have diagnosed end systolic wall stress is increased more than 30. It has become 50, 55. That is the time they have compressed the right ventricle. They have caused IVH. They are not able to take it here. Pulmonary hemorrhage is developed. So both will cause a morbidity to the baby. So what they did is they started milrinone. They have found is better, but at the same time they kept it a PDA. They kept it a PDA. They have taken a nitroglycerin 0.3 to 1.5 microgram per kg per minute. Then beautifully they treated the baby for 3 to 5 days. No baby has developed IVH or anything. No desaturations. And one more thing, Japan is having more ROP because they learnt it. They also want to put immediately bubble CPAP. They also want to put it that now they are stopping it. They are putting on non-invasive HFOV, more better, more brain is saved, more abnormalities, this thing. So I told you one is nitroglycerin, 0.5 to 1 microgram. More than that, it will have coronary dilatation. At the same, more than that, pulmonary problem. This much 0.5 to 1.5 microgram per kg continuously will cause us ESWS low, VCF is increased, baby will be more comfortable. They are seeing all the other things. I told you the treatment, and vasodilators and PDA, I told you. Circulatory IVH, I told you how to do this. That's what. See this, how to do all those things are there. Okay, I told you all those things, what is the dosage and everything. Then thank you very much, dear friends. I don't know how you people are taking. This is the one what I learned. I am telling you. I am whatever I saw, I am seeing, I am treating NICU. Really, I am saving the babies. This is the truth from my heart. Okay. And because treating the baby, giving the cabbage baby instead of that, give the quality care. It is very good. Okay, I'll take 10 minutes questions because today I don't practically not much is there to show. ESWS is the only one. All the other things I showed you already. I am Kamal sir, I am ready to take the questions.
Hello, Dinakar.
Ha, sir.
Sir, I would like to know, you are commenting about the Japanese and Indian or geographically, regionally wise.
Ha, sir.
What is the difference you find? Because mechanism of this one and treatment wise, there will be minor errors or minor mistakes or minor.
Sir, we are also.
Yeah, continue.
Hello. Yeah,
Hello.
sir. We are also using, sir, still in India, many people do, we all use dobutamine. Still we do use dobutamine. Even I do, for the more bigger baby, I do use dobutamine. But how many we people are seeing ESWS? Show me one person in India. Show me one person in India who is doing end systolic wall stress. Show me one person.
In India.
End systolic wall stress and starting this. Not even one I have seen. That is the reason many small babies will die up with either IVH or pulmonary hemorrhage.
So both the things are expected in this situation.
Yes, sir. It will happen, sir. And only thing is, try to, is there any, till now anybody heard only Cardiac output will increase in the warm shock. Cardiac output will rise in the warm shock. BP will come down. But BP is normal. BP is normal, but cardiac output is low. How can you diagnose? This is
Yeah,
the
when the
only
BP
one
is
thing
normal, the
you
cardiac.
can diagnose with ESWS.
Yeah. Okay, fine. Thank you.
Anybody wants to ask anything? Dear friends, if you'll ask me only, I will have a pulsations or stimulation to teach. Okay, can I show how to do the ESWS, or can I show all the other things? Kamal sir, can I show live, sir? Ready? Camera is ready. Can I come? Prashant? Hello, Prashant?
Yes, sir.
ಪ್ರಶಾಂತ್ ಈಗ ನಂದು ಕ್ಯಾಮ್ರಾ ಸ್ವಿಚ್ ಆಫ್. ಕ್ಯಾಮ್ರಾ ಹೆಸರೇನಮ್ಮ?
ಆಗಿದೆ ಸರ್, ಆಗಿದೆ. ನೀವು ಮಾಡಿ ಸರ್, ಅಲ್ಲಿ ಬರುತ್ತೆ.
ಓಕೆ ಓಕೆ, ಹೇಳಿದ್ಯಾ? ಕ್ಯಾಲ್ಕುಲೇಟರ್ ತಗೋಬೇಕು. ನೀನ್ ಕ್ಯಾಲ್ಕುಲೇಟರ್ ತಗೋಬೇಕಮ್ಮ, ಹತ್ರ ಬರ್ಬೇಕು ನನ್ನ ಜೊತೆ. So I am taking the probe. So first, dear friends, already I showed everybody what is fractional shortening. First I will show you, then I'll come one by one. Okay, I have watched. Okay, I am taking the probe. I am putting the gel on the probe. They can see. Okay, so this is the baby. Baby is very comfortable. I washed my hands. I am taking the probe. This is the left side. Okay, and this is my machine. So I told you I am I'm going to show you people what is the fractional shortening. Fractional shortening can be taken in two ways. Number one way is very clear: parasternal long axis or parasternal short axis. I'm going to keep this is parasternal long axis. This is exactly what I want is correct. And I am freezing. See, which is the mitral valve where you people can see. This is the LA. This is the LA, aorta valve, LV, aorta. This is intraventricular septum. And I have to put my probe. M mode here. If I am putting my M mode here, I will get the things. So I got now my M mode. Okay, this is the, so what I am seeing, you people can see it here. This is the left ventricle I can see. Now, please see, we are going to show what is the formula for this thing. Can you see the formula?
Fractional formula.
Left ventricular,
Diameter.
interior diameter, internal diameter. And how to measure it? Left ventricular internal diameter. Okay, I'll tell my postgraduate to write down. So max to max, internal wall to internal wall. I have put it here. Okay. Okay. 1.72 centimeter.
Yes.
Minus 1.72 centimeter over. Now come to the, what is this? Is called a left ventricular internal diameter during the systole. Okay, this is 0.918 divided by left ventricular, same thing, diameter into 100. Okay, please see this, show this. So calculate. So it is 46. How much it is? 46. So Fs should be more than 25 to 45. So it is 46. That means this baby's Fs is normal. You people can see. So just cube it. What you mean by cube? This is ejection fraction. We are not doing in the NICU. 1.72 cube minus 0.918 cube into 1.72 cube into 100%. I don't want to do this because since it is normal, I am not going to do anything anymore this. Now you got this. So now on the same thing, I am going to do the MCF. What do you mean by MCF? What do you mean by the MCF? Means velocity circumferential fiber shortening. What it needs is two things it needs, dear friends. What is this needs? Two things. One is left ventricular. This is the formula. Please see, this is the formula. Above one is the formula. 0.334 into, everything is feeded in the computer, but I am trying to show to the postgraduate. They have to do in their hand. That is the reason I am writing. How I learned, I am making you people to learn. Everything machine will tell us. MAP means mean arterial pressure. Systolic already it is there, 0.918. Then posterior wall thickness. I need mean arterial pressure. This baby's mean arterial pressure is 57. Okay, 57 is there. Now IDS is, we got it. Nidana, ಜಾಸ್ತಿ ಅಲ್ಲಾಡ್ಸ್ಬೇಡ, ಜಾಸ್ತಿ ಅಲ್ಲಾಡ್ಸ್ಬೇಡ, ಹಂಗೆ ಇರು. This is okay. MAP we got it. This we got it. Posterior wall thickness we need. Posterior wall thickness during the systole. Try to remember. So now I am going to go slowly here. See, what is this posterior wall thickness? This is the one posterior wall. Sorry. See, I am showing here. This is the one posterior wall thickness. How much is this thickness? Is, okay, it has not come. Yeah, it has come. 2 to 1. Distance is 2 to 1. So, yeah, very good. 0.334 MAP is into 54. IDS is 918 divided by posterior wall thickness is 221. Means 0.221 centimeter. Once again this. How much it is there? Can you calculate? ಇವೆರಡು ಫಸ್ಟ್ ಕ್ಯಾಲ್ಕುಲೇಟ್ ಮಾಡಬೇಕು. ಯಾವ್ದು ಹೇಳು? posterior wall thickness. Posterior wall thickness 221 into LVIDS. LVIDS ಎಷ್ಟಿದೆ? 0.991. Yeah. Come, slowly you come. See, this is called VCF. Velocity circumferential fiber short. Sorry, this is not VCF. This is called ESWS. End systolic wall stress. First 0.334 into 57 into IDS. ಇದೆಷ್ಟಾಯ್ತಮ್ಮ ಇಷ್ಟು? ಇದು ಮಾಡು. ನೂರಮ್ಮ ಕ್ಯಾಲ್ಕುಲೇಟರ್. ಇದು ಸೊ 0.221 ಇದೆಷ್ಟು? 1 plus 0.2. ಓಕೆ, ಡಿವೈಡೆಡ್ ಬೈ ಇದೆಷ್ಟಾಯ್ತಮ್ಮ? ಇಷ್ಟು ಫುಲ್ ನೀನು ಇದು ಮಾಡು. ಸೊ 1.23 ಇಂಟು 0.221 ಎಷ್ಟಾಯ್ತದೆ? 0.221 1.23. ನೀನು ಇದು ಇಷ್ಟು ಮಾಡು. 0.27 ನೀನು ಮೇಲೆ ಮಾಡು. 17.47. ಇವಾಗ ಮೈನಸ್ ಮಾಡು. ಇದನ್ನು ಇಂಟು ಇದು ಡಿವೈಡ್ ಮಾಡು. 0.27 17.47 divided by 0.60. See, this is ESWS is 64. It is coming. ESWS is coming 64. Why it is 64? It is just now delivered baby. So this baby is having more end systolic wall stress. Normal is 30 to 45. So as if it is in the preterm, if it is more than 45, do you think you want to give dovitamin as I told you? This is a term baby, it's okay. See, term baby itself is little more. Okay, but in the preterm baby, if it is going for more than 45, 50, it is more. And the PDA is also there as it is in the increasing trend. So it will have a more complication. Now, what is the MCF? I want to see this. Velocity circumferential fiber shortening. What is the formula? Same LVID D minus LVIDS divided by LVID D into LVET. Okay, how to diagnose here LVET in the same picture, but I am not able to take anywhere what to do. But we can take LVET from systolic to maximum, systolic to minimum. This distance itself is a LVET. Either you can take from here to here, RR interval. Okay, I'll try to take it and I will show you. Can you calculate this LVID? This 46 bantalva percentage allo, idu 46 kodi. So this has come 46. Not ಇದು ಪರ್ಸೆಂಟೇಜ್ ಅಲ್ಲ, 4.6 0.46 0.46 ಇದು ಮಾಡಿದೆ ಎಷ್ಟು ಬಂತು? ಇಲ್ಲೇ ಇದೆ ಅಲ್ಲ, ಇದು ಕ್ಯಾಲ್ಕುಲೇಟ್ ಮಾಡು, ಇಂಟು ಮಾಡಬೇಡ ಮಾಡು. Now I am going to go new thing I'll take because I have pressed it. VCF, velocity circumferential fiber shortening, same thing, just I want LVET. How I will do the LVET? Please dear friends, how to do the LVET here? I am going to do LVET from this portion. Okay, either anyway I can do LVET, it's not a big issue. Either in this line only you can do, or we can do it here. Come to the, what is this? Anybody can tell me which view it is? 4 chamber view. Yes or no? So what I am opening? I am opening aorta. What I am putting? Pulse wave Doppler. I am taking pulse wave Doppler. What is LVET? Left ventricular ejection type. That means from here to here is the left ventricular ejection type. .290 seconds. Yeah, see that. So how much it has come? It is coming almost, if you will take in a, this is all, what is the time in seconds? If you will take in a millimeter, it will come 1.3. 1.3. 1.3 if it is coming. So what is the normal we need? More than 0.8. So VCF is normal, but ESWO is slightly high because it's just now delivered. So that is the one I am telling. If it is in the preterm baby, that will slowly within hours, within minutes, within any time can develop IVH. Be careful. Okay, because in the term babies, the good cementing is happened in the brain blood vessels, but in the premature baby, it is not. So 1.3 is a normal one. Now come to the, so I showed you how to do the ESWOS. I showed you all these things. Please see this now. Can you show this? FS I showed you, EF I showed you, VCF I showed you. So this VCF, right, 1.3 into RR interval. How to do the RR interval? You have a square root, no? Square root. Okay, what is meaning of RR interval? RR interval means this is the 1 to 1. This is the place is in same time from here. Means starting 1 to, see this is starting and this is the once again starting. This is called RR interval 439. Square root estimma 439. Inge 439 in square root illa. It's not there. It is. Ah, ide. 0.418. 0.418. 0.418 square root is 0.6. 0.6 into 1.3. Same thing. 11. See, I am going to show you this. 0.6 into 1.3. So 0. See. VCF into square root. This is a corrected for the heart rate. It has come 0.78. The normal is 0.8 to 1.2. So I showed you all the calculations, what to do, what not to do. That's all the things. And come to the diastolic functions. Where is that other paper? Diastolic functions? Yeah, please. Thank you. Not this. One more. Ade koduma. Yeah. See, this is the diastolic functions. how to see the diastolic functions. Please see this EA ratio, how to see that I am going to show you right now. What I will do, I will catch the once again, I will go to the, come here, to the apical area. Can you see the apical area? Yeah. You can see, I want to see the, mainly I want to see the mitral area. See, I am keeping the pulse wave Doppler, I am pressing. You can see my pulse Doppler is near mitral valve. Very clearly it is in the mitral valve. You people can see I am showing you the heart. I am putting the E and A wave. Baby is moving. Ma, give the sucking pad. Yeah, see, you can see here both the waves, but very clearly baby is moving too much, but I'll try to show you right now once again. I'm able to see now very clear. Thank you. See here, I'm able to see my cursor is here, E wave and A wave. Why A wave is slightly higher? Because ESWO is high here. I was telling you why ESWO is high here, because some amount of systemic vessels are still, it is higher. That is the reason. See, you people can see here, A wave is higher than the E wave. A wave is higher than the E wave because atria is contracting very much to push the blood from LA to the LV after the birth. Slowly, once the SVR reduces, then slowly E wave will come high, LV. But just imagine, since it is a term baby, it's only happening. Just imagine 300, 400, 500 grammar babies. Okay, how to see this now? How the MP? Now I told you diastolic. I want to show you MPI. Somebody was asking MPI. How to see the MPI? Please, I want anything you take. Okay, from here, this portion to this portion. I have taken between E wave and A wave. Once again, E wave starting. So this is the place where IV RT, IVCT and ejection time, everything is there in this. There are two methods I told you to take MPI. One is take simple tricuspid valve each between. So this is one tricuspid valve is coming, next it is next cycle, next cycle, next cycle. In between the place, it contains, in this place, it contains even ejection time also, no, aortic ejection time. But I have taken this. What is the distance now? 0.223. Can you take the pencil? Can you write here only? 0.223 divided by, okay, hold on. Now I will take LVET. I have forgotten. LVET we have taken, no, last time? Yeah, 0. Right. 0.29. Okay. Okay, right. 0.76. What is the normal MPI? Normal MPI, okay, 0. Less than 0.4. It is slightly more. Why it is slightly more here? Because I told you ESWS is more and A wave is more. That means here full heart is pumping very much against the systemic vascular resistance. Whatever, see, one if you will catch, other things will follow automatically. Like mother duck will go, baby ducks will go. Same thing. So now you saw the pulmonary. Now I want to see the pulmonary vein too. For seeing pulmonary vein, I want a high frequency probe. I don't want to take the pediatric. I'll try to take this, the very minute high frequency 12 frequency probe. Okay, I'll try to show the pulmonary veins. And pulmonary veins can be seen in always when you do the pulmonary veins. Somebody has asked me question after yesterday's talk. Sir, why didn't you see crab view to take the pulmonary flow? Dear friends, crab view, what will happen? You can take a left side lower pulmonary vein, probably you can take, but you cannot always your Doppler wave should go parallel to that flow. Then only you will get. It should not be perpendicular. Our angle should not be more than 20 degree. Okay, just I'll try to show you. See, in this view, I can delineate very clearly. This is left ventricle. This is right upper pulmonary vein, and lower pulmonary I am not able to see. This is once again left. See, I can see left upper pulmonary vein. This is right upper pulmonary vein, and I can see here. Please see my cursor if you are able to see. Left upper pulmonary vein, right lower, left, upper, lower, right upper pulmonary vein. I can see. I can see very clearly it is towards the probe. Towards the probe. So in this view, what you do is see once again. In my I think so later we are going to talk about next class about the brain views next class, because if I'll talk too much about the ultrasound, people might not feel good. So I am going to go with the pulmonary. See, dear friends, if it is a stenosis, I'll get more than one. See, I am getting very clearly 1, 2. This is atrial contraction is very high. Can you see atrial contraction? I don't think nobody will get so beautiful things. Nobody will get. Hey, off. Okay, nobody will get beautiful than this. See here, A wave is very, very much high. Why it is very high? Because atria needs, there only we have seen the E and A wave. Atrial wave is very high. See, this is the one. We should not see this afterwards. If you are seeing this, that means diastolic dysfunction is there. In this baby, since it is severely vascular, just now baby born, it will take some time. See, what is this one? What is this one? This is called a, once again, this is called a systolic, this is called a diastolic. Even what happens, usually systole should come up, diastole. Here diastole is also high, systole is low. Diastole is also high. That means this baby needs more, probably, I don't know, I have not attended this delivery, either intrauterine something, baby might have developed some amount of hypoxia. Still, but it will recover on its own. So indirectly, everything we can tell what has happened to this baby, or it might take more time since it is a term baby. Okay. Anything else? This is called a pulmonary vein. I have showed you. Then pulmonary vein is over. Superior vena cava I should show you. I'll show you. That is the things. 1 minute, dear friends. You can see here. Please come. See, this is the probe. I am keeping this one high and I am pushing this one. Oh. Oh. Okay, I think so. You can see now. See, what is this view? Anybody can tell me? I think so. You are able to see the vein. ಧನ್ಯ ಹೊರಗಿಡು ಎಲ್ಲಿ ಕರೆಂಟ್ ಬಂತು ನೋಡ್ಕೋ ಏನ್ ಸೌಂಡ್ ಬಂತು ನೋಡ್ಕೋ See, this is the one where innominate this thing and what is that innominate artery and pulmonary SVC is coming. Now just I am going to show you. No. I think so. You can see very clearly. You can see this is the right atrium. You are able to see now very clearly. This is the one from here to here. I measured the superior vena cava. Now clear it. Okay, maybe he's vomiting. I think so. Everybody can see superior vena cava is coming and joining to the RA. Is it more clear? More clear. Superior vena cava is coming and joining this thing, and this is the where you people can measure it. And length is. This is the way and flow. How to see the flow? This is the way to see the flow. This is called a subcostal view. How to see the flow? Please see, dear friends. Now we have taken it is 4.2. Now, okay, I have to take for this is a pediatric probe because we might not get. ಧನ್ಯವಾದ ನಾನು ಮಾಡಬೇಡ ಅದನ್ನ ಎಲೆಕ್ಟ್ರಿಕ್ ಬಂತು ಕರೆಂಟ್ ಬಂತು ರಿಪೇರಿ ಕರೆದ್ಬಿಟ್ಟು ಕೊಡು. Yeah, see here I am taking the pediatric probe. I am seeing this. I'll take only few seconds now. See, dear friends, you can see now. See 4-chamber view. I am going slightly upper side towards the right. Yeah. See, this is aorta, where you are. See, in this I can see very clearly, very clearly, right lower pulmonary vein I can see, right upper pulmonary vein I can see very clearly, and I can see from here. And that is ASD also I can see. Yes. Clearly, you people can see what superior vena cava flow. Put the Doppler here if you want, then you can see very clearly. See here also you can see S wave, D wave, A wave. All the three waves you can see very clearly. S wave, D wave, everything you can see here. S wave, D wave, everything, and A wave. But A wave is also seen. S, D, A. Okay, that is called systolic, diastolic, and atrial contraction. All the three waves you can see. If you will measure from here to here, that is called VTI. From here to here, if you will measure, put the trace, press this thing, tracking, and you can go ahead and measure the, clear it, put the trace, select it. Okay, you have measured it, trace, select, this is completely, we got a VTI of almost 14 or 15. It's a 15, it has come. So measure it, SVO outflow tract measurement and VTI into 0. I showed you 0.785. It will give you what is the SVO flow. I told you how much it should be minimum. It should be more than 45. If you want, you can calculate here also. You want me to, because already now it is 4:30, time is getting over. Next class, whenever I am doing the congenital heart problems, that time I'll show you. Now I showed you how to do the method of calculation. That is more than enough now. Okay. You can show my face now. I think so 4:30, no? Because people have to go for there.
Thank you,
Any
sir.
doubts you people are having, please ask me.
So thank you, sir. You had very elaborately gone through how to assess systolic function. Then you showed us how to calculate fractional shortening and also ejection fraction. Recently, we had a baby with dilated cardiomyopathy, and this baby's fractional shortening was low, less than 0.25, and
Less than
the
20. Okay,
cardiologist The cardiologist came and told us even the ejection fraction is low, but we didn't know how to calculate it. You very easily showed us how it is, and you have to cube it, and then you'll get it. It's almost
Sir,
the same formula.
all the things Dr. Prashant Gowda is going to put in the YouTube, sir. It
Ah,
is
yes,
there in
sir.
the YouTube. Even
Yeah,
all
yeah.
the
I will
classes
send the
except
link,
the
sir.
first class.
Ah, yes, sir. Yes, sir. Thank you, sir. And
I
you
will
also
send the link, sir. I will send the link.
this calculating SV. I mean, getting the SVC flow has been always very difficult. Even our cardiologists don't. Tell
Sir,
us
it is
anything about
very easy,
SVC
sir.
flow.
2 minutes, sir.
Yeah, yeah. So you have told us very clearly, sir. Thank you, sir. Thank you so much. And it was very interesting class today. I think
Sir.
now we are going to write out in our ultrasound machine. And this new
sir.
concept you told us, sir,
Ah.
just wall stress, end systolic
sir.
walls, early systolic wall stress. That is a new
Sir.
concept, sir. We have not tried it at all. I think we should look into that also. And that
Sir.
will also be included in the YouTube video, sir.
Sir. Everything is there in the YouTube, sir.
Yeah.
Even actually, we need more discussions.
Yes,
Otherwise,
that's
people, it
right.
is like one way, it will become one way, sir. We
Yes,
need a more
yeah, I
discussion.
understand. Yes, sir. I'm just velocity of circumferential value shortening. That concept also is very new to us, sir. VCF.
Sir.
We have not attempted it all this time. I think we should start
Sir,
doing it.
VCF, you are, sir, I cannot hear you, sir.
So what I said was VCF also is a new concept. We are not tried it at all. Now that they explained it to us, we will start
Try, sir.
attempting to
It
it.
is very, very easy, sir. Very
Yes,
easy. Only
yes.
thing is, you make your calculations more easier. And you, sir, in front of you, I showed you, sir. All
I
the
know you
values
thought,
has
yeah,
been
yeah.
kept.
Yeah, yeah, now it's clear. I think we should try it now in our department.
Yes,
Thank
sir.
you, sir. Thank you
Thank
so
you very
much,
much,
sir.
sir. Thank you very much, sir. Sir, you encourage all the students to do the echo,
Yeah,
sir.
all our students they are logging into this for this session.
Sir.
And not only my students, the other neonatologists also in the city are logging
Sir.
onto this session.
I am there with you, sir. I am there with you. Sir,
Good
anybody
afternoon,
wants to
sir.
ask any question?
Sir, good afternoon. Sir, I'm Dr.
Sir, good afternoon.
Atul Londe from GMC Aurangabad, sir. Hello, am I audible, sir? I want to just ask one question.
Sir, 1 minute, hold on, sir. 1 minute.
Yes.
Yeah. Sir, please tell me, sir.
Sir,
Can
I'm
you
Dr.
hear me
Atul
now,
Londe
sir?
from GMC Aurangabad, sir.
Atul, bolo.
Yes, sir. Sir, how to decide about inotropes depending upon ESW's values?
Sir, simple it is, Atul. See, what you
Yes.
do is number one word. One word. Please try to do for all small babies ESWS number one. That calculation is there with you right now.
Yes.
You have taken.
Yes.
It is very
Yes.
easy calculation.
Yes, sir.
Do it. You write it down. 30 to 45. 30
Okay.
to 45 gram per centimeter square is normal.
Yes.
30 to 45 gram per centimeter square is normal.
Okay, sir.
Once you get that, all the things you should do it in centimeters, not millimeters.
Okay.
LVID, then MAP, whatever it comes in the monitor, you take it.
Okay.
So 30 to 45. If one thing you should, at the same time, VCF corrected, you do it.
Okay.
I don't have time to do the VCF, means
Yes.
you write down.
Yes, sir.
3.76
Yes.
into ESWS,
Yes.
just above minus 0.4, just above the ESWO4, you know, O2 we will write no 2, O2 we will write no, like that ESWS just
Yes.
above the 2 like that, minus 0.4. So once you get the ESWS, minus 0.4 into 3.76.
Yes.
That you will get it exactly what is mean velocity circumferential fiber shortening. If you don't know how to do the VCF, there is other calculation, easy one is there. So if you will do it, see ESWS, if it is coming down and VCF both are coming down, you need a ionotrope. Ionotrope means constriction, dopamine, epinephrine, you need it. Suppose VCF is coming down, ESWS is rising, you need a ionodilator.
Okay.
Ionodilator.
Okay.
Okay. Because
Yes, sir.
ESWS is increasing, so VCF is coming down. Both are coming down means you need a ionoconstrictor with the volume.
Okay.
So suppose VCF is high. VCF is high. Okay, ESW is normal. Follow the trend every hourly.
Okay, sir.
And regarding the PDA, regarding the right PPHN, won't much bother the ESWS. Remember, there is, because if you'll go read tomorrow, or if you're going to do something, you have a confusion, sir. PPHN will compress the right heart, no? PPHN will increases the right ventricle dilatation. IVS it will compress. That time it will cause. There is no much effect on the ESWS.
Yes.
Not much, but VCF might come down. But ESWS will be normal. That is one catch here. That is the reason.
Okay.
If FS and EF is depending on the preload and the afterload and heart rate, but VCF is almost everything it overlooks and it will give a correct answer.
Okay.
From today, I request everybody to start. We also should learn all those things.
Yes, sir.
Then any doubts, sir?
Thank you, sir. Thank you for guiding.
Thank you, sir. In which case, can we close the session, sir?
Yes, sir. Yes, sir. Please, sir, give the closing note, sir.
Thank you, sir. Thank you so much. And I thank all the participants who have benefited from this classes. And a big thanks to Dr. Dinakara sir and his colleagues and his team for very patiently and going through these subjects which are actually not really known to us. We have not attempted it. We might have read books, but we have not seen it personally, and we have not done it on our own, even though we have a echo mission in the department. So thank you, sir. Now this is actually kindled a fire, and we'll go back to our machines and start doing these things and calculate. Sir. Only then we'll have more. That's what my opinion is. And one thing which you cleared me was what is IVC contractility and collapsibility. What is IVC collapsibility and distensibility? So
yes,
we were the ventilated baby, you call it a distensibility, sir.
Correct,
and
sir.
Spontaneously breathing baby, it is collapsibility.
Yeah, easy, sir. Because ventilated distance means CDP, continuous distending pressure, so distensibility. No, sir, it's all. That's the reason I told, please, this talk is a spoon feeding. Whoever doesn't know, please take it. Take it. I am feeding you. Please, please.
Thank you, sir. Thank you so much.
And sir, next class will be Dr. Prashant will be taking about the. I'll be taking about echo in the shock. I'll take later, and the congenital heart disease I'll take later. Dr. Prashant Gowda will be taking next Tuesday about the normal views of the brain. Tuesday from 2 o'clock. Then that little we will give the relaxation time, sir.
Yeah, from heart, we'll now connect to brain, sir.
Okay.
We'll give rest to heart. Heart is pumping too much. We'll now start using the brains.
Right.
Thank you, sir. Nice.
Thank you, sir. Thank you, sir. Thank you, sir.